Good afternoon, everyone. I'm Maria Malopoulos, Scientist and Associate Director of the Wilson Center. And on behalf of the Wilson Center and the Center for Faculty Development, I'd like to welcome you all to What Best Practice in Education Rounds. Please note that this session will be archived on the Center for Faculty Development website. Also, if you wish to see a live transcript of today's session, please turn on your closed captioning at the bottom of your Zoom screen. I would like to begin with an acknowledgement of the land on which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the Center for Faculty Development and the Wilson Center are located that precede the establishment of the University of Toronto, Unity Health Toronto, and the University Health Network. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa Band. Since these rounds are a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are a few places on Earth that someone before us has not called home. I encourage you to consider your own position with regard to the land where you find yourself. And if you're not sure how to locate the Indigenous territories, treaties, and languages that shape both the past and present of your current location, I invite you to take a moment now to look it up. One of the benefits of this virtual format is that we can make use of virtual resources. Take a moment to open up another browser window, type in native-land.ca. It is a crowdsourced interactive map built around principles of land as pedagogy. The intention is to use these resources as an opportunity to critically engage in discussions about colonization, land rights, language, and Indigenous history. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. It's my great pleasure to introduce our chair for today's session, Dr. Patricia Houston, the Vice Dean of Medical Education at the University of Toronto. Throughout her career, Dr. Houston has distinguished herself as a collaborative leader in health professions education. She has served in a number of leadership roles, both at St. Michael's Hospital, where she served as Vice President Education, Medical Director of the Perioperative Service Program, and Anesthetist in Chief. At the University of Toronto, she was Vice Chair of Education in the Faculty of Medicine Department of Anesthesia from 2004 to 2011, and in 2016 became Vice Dean of the MD program. Recently, her role has been expanded to Vice Dean of Medical Education. In this expanded role, Dr. Houston retains responsibility for the MD program with additional oversight of postgraduate medical education and continuing professional development programs. Dr. Houston has been recognized with numerous teaching and leadership awards. I would argue that this is because across the educational programs she oversees, she is dedicated to ensuring excellence and alignment built on evidence-based best practices that include wellness, social justice, and a commitment to fostering a learning environment where we all belong. On a personal note, I've had the privilege of experiencing Patricia's leadership and mentorship firsthand, and I can't say enough about her integrity and unwavering support of those around her in every aspect of their lives and work. I can't think of a better person to guide us through what I'm sure will be a stimulating discussion with the wonderful trainees who have made time to be with us here today. Dr. Houston.
So thank you very much, Maria, for those very kind words. I do think we're going to have a very interesting session today, and it will be notable that we have learners from across the continuum of education, because I consider myself a lifelong learner as well, and I would be in the older faculty category. So a few housekeeping notes before we start. If you think of questions, we will answer them at the end of the four presenters, and please put them into the question and answer box. I'll be looking at them throughout the session, and I will give speakers opportunity to answer these, as I said, after all four have had a chance to speak. And at the end of this, if you would please fill out a short evaluation form for us, that would be very much appreciated, because we want to know how we can make these sessions as meaningful as possible for all that attend. So without further ado, I'm going to introduce our speakers for today. The first is Dilshan Pieris. Dilshan is a second-year medical student, and he is Vice President Education for MedSoc at the Temerty Faculty of Medicine, U of T. He did his undergraduate at McMaster University in Health Sciences Education, and also did he also completed a master's there. Many of our students come from McMaster. In fact, at one stethoscope ceremony, one of the leaders said, "Turn to your right, turn to your left. Oh, say hi to your friends from McMaster." Anyways, he is also a member of the Wilson Center and the McMaster Education Research Innovation and program, the Merit program, and he sits on our curriculum committee in the MD program. Next is Jason Kwan. He's a third-year student, and he is the immediate past Vice President MedSoc for Education. And Jason also sat on our curriculum committee. So both of these students have had an opportunity to understand how Maria and I, as co-chairs of that curriculum committee, oversee the review, the revision, the development, implementation, and most importantly, evaluation of our curriculum. Jason completed his undergraduate degree at the University of Ottawa, and he is specifically interested in curriculum development. Next, we have Victor Doe. Victor is a PGY1 in pediatrics, and he went to medical school at the University of Alberta. And he is the immediate past president of the Canadian Federation of Medical Students. And I've had the privilege of working with Victor when he was in that role, and he continues as the immediate past president and board chair. And he had huge input into how we managed medical education as the pandemic arrived and as we learned better how to manage it. And last but not least is Brittany Prevost. I hope I've said that correctly. And Brittany is a fourth-year resident in anesthesia at the University of Toronto. And I, of course, am an anesthesiologist and critical care physician at St. Michael's. She did her MD and her master's in science at U of T. And she's actively involved in the co-creation of competency by design curriculum within anesthesiology and is a member of the program advisory board for the Royal College's International Conference on Residency Education, which is actually being hosted in a longitudinal fashion as we speak. She's currently pursuing a Master's of Science in Health Science Education at McMaster, and her interests are in simulation and in the assessment of non-medical expert competencies in residency education. So all of these learners are going to tell us about their experiences during COVID, their stories, so to speak, what's been good for them, what's been not so good, and what they have learned. So Dilshan, if you would start, please.
Thank you so much for the introduction. I'm very happy to be here to speak with all of you about my experiences. So I thought I'd start off sort of by setting the stage of like going back in time to the beginning of COVID before sort of all the changes happened with education. I was just anticipating my March break in the middle of March. And I packed a small duffel bag to go home, expecting to go home for a week and then maybe 2 at tops because COVID was just sort of rearing its head. And I thought I'd be back soon, but then I did not come back for the rest of the school year. I stayed at home for what I thought was going to be 1 week, but ended up being 6 months until the following school year started this year. And it was definitely a time defined by uncertainty because at the time I was unsure about how long I was going to be home. I was with my family, but I was away from many other social supports like my partner and my friends. And as many other people on the panel can likely attest to, it can be sometimes isolating when you're away from other people during the pandemic. So that's sort of how my COVID experience started. In terms of the education, we were still in the school year at the time. So I'll start off by talking a little bit about what our education was like before COVID and some changes that happened afterwards. So the first major change that happened abruptly was the cancellation of our in-person clinical skills. And for some of us junior learners, clinical skills is basically a time every week where we get to practice physical examination techniques with our group and with our tutors and go to the hospital and see patients. And that was a very valuable experience that we had before COVID because we got to just actually see real patients, the people that we'll be interacting with and caring for in the future, as well as getting some practice or techniques that would be really important for us to learn as we move on to our practical experiences in clerkship and beyond. In terms of other experiential components, there's also shadowing. So many medical students throughout med school wish to engage in shadowing as a means of career exploration, as a means of getting clinical exposure to specialties that they are thinking about pursuing in the future. And this was also stripped away from us with COVID. We were not able to go to the hospitals to explore anything. And for many students, myself included, this left us feeling a little bit anxious about sort of pursuing careers and exploring different options and meeting important people who could be useful connections for us in the future. And just overall just getting experience in the clinical environment. The third component of that was taken away was our anatomy labs. So before COVID, we had access to cadaver labs, very, very important experiential component of our learning to facilitate our anatomy knowledge. We were able to have dissections in class. We were able to explore different specimens and put our learning into context and see the real variation of the human body. But without that, our learning was transitioned into an online format. So all of these different aspects of experience were taken away due to COVID. In terms of other things, lectures, going to class in person, these things that we took for granted before COVID. I know like it's hard to wake up in the morning and go to class, and many students didn't think twice about it. But then when COVID hit, we started, just those little connections, like when you take a coffee break and you see your friends there, or just the engagement of sitting in a classroom and seeing the lecturer present in front of you and being able to see their excitement and them being able to see you engage with the material and asking questions. All of these small little things were things that we took for granted and ended up not being able to do that anymore, or at least not in the same way. So those are some aspects that were, I guess, considered that were lost for COVID, but it's not all negative. I think there are some important lessons that were taken away from sort of going through this whole experience of COVID and learning in medical education during the pandemic. One thing that stuck with me in particular was the value of mentorship. In U of T, we're really lucky to have lots of mentorship programs offered for students, even before COVID. And with some of the losses that I talked about, these mentorship programs became a really valuable part of my learning. I was able to still have conversations with physicians and residents about, career-related conversations, about personal conversations, getting guidance to them about how to move forward with my journey. And these conversations became really, really valuable for me because it's really one of my only points of contact with some of these individuals. So it's something that I was very grateful to still have. The other lesson or takeaway that I had was around faculty and student communication. Now, this was something that I think was a bit of a challenge in the beginning of COVID. Everybody had to adapt. Our world was sort of flipped upside down, and the faculty had to adapt quickly to give us our curriculum. The students had to adapt to sort of new modes of learning in the virtual environment. And I think towards the beginning, there's a little bit of a disconnect between students and faculty about what was happening on the back end and what was going to happen for the students. And this led to, I think, a lot of anxiety amongst the students and likely a lot of anxiety among the faculty as well. But as we started getting our footing and through much time and learning and making mistakes and all of that, the communication has gotten a lot stronger. We've been having more frequent town hall meetings with faculty where they're giving us updates about what's going on. They're sending more frequent emails to students, including a regular newsletter that's giving us updates about what's going on. And the partnerships with student leaders and faculty have become paramount to bridging that gap between students and faculty in order for us to feel more, I guess, hope and optimism going forward that everything is being done to give us the best training and preparedness for clerkship next year. And lastly, I'd like to just acknowledge that while the pandemic has been a very challenging time, I think it's also been a very interesting time for medical education in that we have to reimagine how we're teaching students, find creative approaches to assessment and learning and delivering curricula. I think in that way, there's a silver lining. And with that, I'd like to thank you all for listening. I'm going to pass it off to Jason.
Hey everyone, thanks for having me talk. My name is Jason, as Dilshan and Dr. Housen has pointed out, and I don't think I can set the stage as nice as Dilshan has, but I can try to describe my time during COVID and now that it's still happening. So I was a second-year medical student when that was, and it was, I remember during that time I was planning on a vacation getaway in the summer, as some of the four-year programs are very lucky to have when everything shut down and my time of relaxation suddenly disappeared. More importantly, being a second-year student, we begin our transition towards third year in clerkship and adapting into and beginning to be part of the team in terms of the clinical environment. And a lot of us, it's a major shift, and we usually use, from my understanding, the latter half of the second year in order to develop or receive critical feedback to help us prepare, receive integration of all of our clinical knowledge from the previous 2 years, just so that we can make the transition as smooth as possible. That being said, with COVID, everything went very bumpy at the beginning, and everything kind of warped and changed, right? Everything, as Dilshan said, went online. A lot of the assessments were online. A lot of our small groups turned into big groups and virtual sessions. So that individualistic feedback that you can get from preceptors to help kind of guide your clinical learning towards clerkship, to be prepared for clerkship, kind of was changed. And I think that was one of the major things that a lot of people were stressed about. This included one of the second year OSCE, which was canceled for the purposes of safety and then reintegrated later at the beginning of third year during our transition to clerkship. Also wasn't done in person and didn't really assess our physical skills, more of our clinical skills in terms of history taking, which was very important. So I think during the entire time, there's a lot of anxiety within my class and within my peers, just because we had no idea what we were heading into. And the upper year class, the third years who are currently in their sessions, were also taken away from clinical duties and also didn't know what was going on. So, and we didn't really know when we were going to go back into the clinical environment and how that would work and what sites we could have, and if the clinical experience that we would receive would be enough to be the competent physicians that we would be expected to be by the end of our 4-year programs. And I think that the faculty and faculties across Canada all work together to address these issues. And here in Toronto, at least, I can say that they did a fantastic job in ensuring that all the students who were in clinical education received the support that they needed, as well as supplementing the clinical education that we needed to be comfortable in our clinical environments. So now I'm in my second year of, or second rotation, sorry, not second year. I'm in my third year, but my second rotation. And now I've been at 2 different hospital sites, both of which have had outbreaks, luckily not on the floors that I've been working on. But it's very interesting to see some of my colleagues who have been involved in those situations and how quickly hospitals and faculty are adapting to ensure that that they still receive the education that they need and the clinical experiences in order to be to meet the standards and be the best physicians that we can be. So in terms of this transitional period, I think there's a lot of things that were done great, including things that Dilshan has mentioned, including fast transitions from the traditional physical curriculum directly into the virtual curriculum, and kind of decisive decisions to protect students immediately, and then keeping student safety in mind while we reintegrated students back into clinical environment. And at least, and for the class, my superior, the class of 2021, and my class of the previous third years, now fourth years, and now my class, which is the third years, ensuring that the double cohort during the clinical environment went as smoothly as possible. And it was actually quite nice because on some rotations you would have upper year students who'd be able to mentor you and guide you during the transition and kind of fill you on what traditionally would have been done at the end of second year is what I feel. Some things that I think needed work on, and as Dilshan has mentioned, was part of that student and faculty partnerships in developing education, especially in terms of student wellness. And I think this is a very difficult question to or topic to discuss or to address, because every single student is affected of each student, and how to support them changes as well. And one example is how do we balance exam integrity, which is done online within the home or within your home, and exam integrity. And I completely understand that this balance is hard to strive for. But at the same time, in order for students to perform and in order for students as wellness to be addressed, I think that proper accommodations should be addressed. And I think that this balance is still being addressed at the moment between students and faculty. But otherwise, that was kind of my experience in a nutshell. Yeah, I'd love to answer some questions later, so I'm just going to pass it on to Victor.
Thank you, Jason. Appreciate your perspective, and thanks for the opportunity to participate today. I'll be talking a little bit about my perspective from a learner, and also in the roles I've had throughout the pandemic with representing learners nationally with the education perspective nationally. So kind of similar to Dilshan and Jason, framing a little bit about what March was like for me. I had just matched about 2 weeks before things really set off. And I remember March 18th very well, because that was kind of the day where nationally clerks were all pulled from their clinical duties. And in my role with CFMS and nationally, a lot of things started to ramp up. But for myself personally as well, I was at the end of medical school. I had 3 weeks left of a rotation, and then would have finished my clinical duties before doing kind of a review block and then end of year exams and graduation. So it was quite a time. From an education perspective, I think what was difficult in March and as we finished medical school was the feeling of, wanting to have finished the clinical training now that you had matched and had some more opportunity to continue to get feedback and prepare for residency. We had some anxiety at the time around whether we would need to, as in some other countries, be pulled into clinical sooner or, quote unquote, graduated early to help with any service requirements. And then many of us also felt broadly that, we could maybe be contributing or at least learning from the experiences, good and bad, with pandemic management, patient care and things on the hospital, which many learners across the spectrum felt. But certainly as students who were kind of in between in the transition period, this was a difficult time for us to kind of know our role. Fast forward to July 1st, how many months after we were initially pulled, myself and the graduating class of 2020 are obviously starting our residency programs, and the transition from medical student to resident is already a big one. And in this case, we had all been out of clinical duties for a lot longer than we probably would have been. And we're coming back to a totally different reality, with regards to screening and PPE and all of those things. All of us have experienced that. And so for myself, I felt a little bit worried about whether my clinical competence could be there, how to really know and transition into residency. and all the additional responsibilities and privileges that come with being a resident physician. And so I've been very lucky. My program has been very supportive. And I think, we've all been trying to get through and go through things together. There's so many things happening with competency-based education, programs that are trying to maintain and continue their transition to residency programs, transitioning between sites and learning all these things. And of course, I moved from Alberta, so I'm trying to learn the health system and everything as well. Has been a real whirlwind. And then in challenging training programs, it's really important as residents and as a cohort group to get to know each other and be there to support each other. And that's been difficult, I think, for a lot of residents in any year, but particularly the PGY1s, because our ability to meet in person and get to know each other and have those important team building social events have been quite restricted. And again, a lot of innovation and trying different things have been employed, but certainly still challenges. So a couple of takeaways from all of that, I think, from the learning perspectives are in reflection and looking back, how in future crises we may be able to better continue to support student learning, even if they cannot be in the clinical environment or there may not be an appropriate clinical role for them. And looking at continued ways to better help with transitions and periods where people have uncertainty and time off, and how we can best utilize that. I'll take a step back and talk a little bit about things kind of nationally and from medical education as a whole. So I had a very interesting perspective. As Dr. Houston mentioned, I had the opportunity to be on a number of national committees and in a number of different meeting settings to try to look at how we were going to realign and do all the things we needed for medical education. And the first, I guess, overall kudos I have to give to all the faculties and all involved was the importance of how everyone collaborated very well and really held learners at the core of the issues and with the decisions and changes that were being made. I think we all had a number of bumps as we tried to find the best way to communicate, the best way to change things, and the best way to ensure everyone has the clinical skills and competence in such a different environment. But I really saw a lot of strong collaboration, teamwork, and focus on an overall set of goals. I think the pandemic has showed too, though, that medical education needs to continue to evolve as it always does. And whether that's with licensing exams or, again, how we administer assessments, how we continue to train and teach learners when you can't necessarily be in person or hold, the same type of group settings or things. How do you continue to innovate and to support faculty to do all this? Because I think there's been a lot of onus on learners to find different ways to do innovative things, and the same thing as faculty. And I think we're still really grappling with, how do we get to a place where we can have better faculty supports, a more common set of principles in regards to, how we adapt and change things in education setting, things from there. And I think from the learner perspective, the other, I'm sure Jason, Dilshan, others who have been involved in leadership will note there's a lot of heavy burden on our representation and the amount of work that's done. I think at my peak, I spent about 78 hours a week when I wasn't in clinical on all of these things. And so again, everyone was always really supportive, and I know faculty spent hours and hours and hours above and beyond what they normally would have done. So I think for all of us, as we continue to move and evolve in this, knowing that even with the good news of vaccines and all those things, we're in this for a long haul, to really be there to support each other, ensure that wellness continues to maintain and continue to be maintained as a top priority in all the discussions and things that we have. And then that as we shift out of, crisis management, which we've kind of come from at the beginning, in March, April, or whatever, we were maybe more in a crisis management mode. We continue to deal with things that come up, whether it be outbreaks or unexpected events. But as a whole, we've moved into a different phase of this, and to really look at how do we evaluate all the things that we're doing differently. How do we keep the good things that we've identified? How do we prepare for something maybe not this scale to ever hopefully happen again in our time in education, but likely other crises and events, and just really take a lot of opportunity to learn and reflect on it. Because I think for many of us, we've been going full steam 24/7 for months and months. And it's time to have opportunities like this to really talk about what was effective, what could be better, and then what the next steps are. So look forward to engaging in the discussion at the end of our talks. And I'll now hand it over to Brittany to wrap us up.
All right. Thanks, Victor. So as was introduced, my role during the pandemic was in the middle of my residency program. I was displaced from scheduled anesthesia rotations that were largely elective, sort of ambulatory in nature, and spent 2 months working in amongst COVID patients in the intensive care units in Toronto. I'll start by speaking to the good of my experiences, because I think there was a lot really that came out of that that were sort of formative in my experience thus far in residency. I think, and this is very much true of spring COVID and maybe less true of what we're coming into now as people have sort of got fatigued, but in the spring, it really felt like you were an individual part of something bigger, part of an overall sort of call to arms with a skill set that you could bring for patients that needed your help. And so it really was, I think, motivating on a bigger level to see, you know, in amongst my resident cohort, a number of us hitting the ground in the intensive care units, to go to work in intensive care and actually see in the weeks prior to me getting there what the different health professions had been doing to try to build capacity. And so there was nurses looking to train other nurses in the hospital around different things that they'd be able to bring to intensive care. I was part of a bit of a critical care and anesthesia group trying to put together basically crowdsourced resources and really trying to pull together information on a very much a real-time basis so that all of us could feel like we had what was the most recent recommendations for intubation protocols, for PPE, for the appropriate ways to don and doff. And so being part of that bigger thing really was motivating and kind of gave very much a purpose to the day-to-day that I was going to work and coming home in a time when the entirety of Toronto was largely at a standstill. Another thing that I think sort of fits into that as far as good experiences is really appreciating around me how I think the hierarchy had somewhat flattened, certainly to what we are used to in our usual sort of approach to doing rounds and presenting things very much in a you know, resident leads and then fellow speaks and then staff finishes and then other health professions sort of add to the rounds in the intensive care unit. And all of a sudden it was, you know, everybody really, I think, working together, again, to deal with things that were somewhat unprecedented, medication shortages that left us looking at different ways to manage sedation and pain management in the ICU, and that being something that, you know, anesthesiologists have a lot more familiarity with, and the pharmacists in the hospital being able to tell us what we thought we had in terms of stocks and things. And I think just this appreciation that we were all sort of on an uncertain footing as far as, you know, knowing that Toronto was having certainly increased COVID numbers, but whether that looked like you know, busy ICUs and sort of a presence of COVID, or whether we went into full, you know, sort of surge capacity, fluxing into the operating rooms and running out of ventilators. And there was a lot of stories coming from trainees and physicians in Europe, different areas in the United States. And so there was this sort of day-to-day wondering about what was going to play out for us and how this was going to, what it was going to look like. And as the spring continued and we sort of got from March into April and into May, the actual necessity of having enough PPE was, I think, clear to all of us. And, it became a sense that we weren't going to become totally overwhelmed. But there still was this sort of, I think, appreciation that we were all more sort of vulnerable in this environment. And I really felt like the staff, the faculty that I was working with had created space for us to ask questions, to be uncertain, to really normalize the fact that nothing about the experiences we were having in our residency day to day were in fact normal, so to speak. And all of that really, I think, left me with a real sense of pride coming out of the few months that I did working there. And when things sort of slowed down, going back into anesthesia rotations and being able to speak to people in anesthesia who asked, how was that time redeployed? I could speak to a lot of these high points. I think as far as things that were challenges or the bad, this sense of vulnerability really, again, sort of changed our day-to-day in ways that I think as residents can be qualified as things that were bad. I got the sense in talking to colleagues and felt myself as well, that there was a concern that residents might be viewed as almost a never-ending workforce, and that there could be times where residents, particularly after hours, are going out of their way to take care of patients and not necessarily feeling like they have the support of faculty, or whether faculty would be stepping up and seeing COVID patients as and sort of quote unquote putting themselves in harm's way as well. And this was reflected in seeing details come out about sort of unprecedented, like COVID danger pay almost, and how residents were actually not included in that, despite doing a lot of legwork on the ground. And the other thing about, I think, residents feeling vulnerable was just, particularly among us who were more likely, either more likely to be redeployed because our regular rotations were disrupted, or more likely to be redeployed because we had a useful skill set. There's a concern of how do you make that redeployment workload shared equitably, and in a time of competency-based medical education, how do we make sure that we're giving people the opportunities to achieve competencies? Because at the end of the day, I think what most residents are concerned about is not about losing time and sort of taking care of COVID patients when they need to and they need to step up to the plate, but is actually, am I going to lose so much time that this extends my residency training or puts me into a situation where maybe I have difficulty achieving technical skill competencies? And I'll finish just with a few thoughts around really lessons learned from these experiences. And it feels less like lessons learned in a sort of true past tense and more like moving forward. What do I think we need to be thinking about anew, because we're now in Toronto in particular, a couple of days into a brand new lockdown with numbers increasing. And the main takeaway that I would sort of suggest is really for all of us to think very deliberately about how we create space for residents to feel safe. I mean, this is learning on the job and it's learning in the workplace, but with a new challenge and a new layer of uncertainty to our day-to-day. And so like I said, I really felt a flattening of hierarchy and a welcoming of an openness for questions and for, really making sure each of us felt like we could manage our PPE and keep ourselves safe. And that, when the block switched over and I was one of the individuals who had stayed on board, for me, it felt really important to touch base with the new residents joining us and say, what questions do you have about how we're doing things here? about PPE? Can I show you where things are? You know, this is what I do when I go down to the emergency department, and really making it feel like a comfortable environment for all of us, and to know that this vulnerability and this sense of safety, I think, extends beyond just our time at work. There's really, I think, now an intersection between who we are at work and what's going on in our personal lives that I don't think was quite the same pre-COVID. And so worrying about family, worrying about bringing things home, worrying about family members out of province, or things that are going on outside of work, and how that can actually affect you, your wellness and your burnout on a day-to-day as a trainee, I think is absolutely critical. We need to make sure that trainees feel supported, that there's avenues for them to share experiences. And so I was very fortunate that some of the trainees in residency programs in Toronto set up essentially open Zoom chats for us to join at different times in the evening and just talk about what life was like. And it was really valuable for me to hear, you know, family medicine residents talk about their experiences in COVID screening clinic, a psychiatry resident talk about his time working in the emergency department, and really to normalize that. And I think I'll just finish by saying, I think all of this is doubly important, because unlike the spring, what we now have is an increasing wave of COVID burden that's actually more universally across the country, I think, than it was initially in the spring. And we don't have that same purpose, call to arms sort of sense of pride. And so I think we need to be even more deliberate about how we build the resident environment to make sure that we support trainees coming up this winter. And so that's more or less what I have to share. Let's go back. We can go back to Dr. Houston and the questions and the rest of the participants. Thank you guys for your attention.
Well, thank you to all of our participants for sharing their stories. And it really is, it's sharing your personal experience, and not just how it impacted on your education, but how it impacted on your life and those around you. And I'm going to share, and there's no questions yet. Please do ask some questions. I'll just share for a couple of minutes the two things that I dealt with. So on March the 13th, I was on call for CV anesthesia and CVOR, and I did a very sick case that was a patient that was transferred in from another hospital urgently with a post-MI VSD, already intubated on a balloon pump, coming to the OR. And it's like your worst nightmare. The only thing I could say was that we couldn't we couldn't test for COVID, so we had to treat the patient as if they were COVID positive at that point in time. And I had to really, really quickly try to sort out how I was going to don and doff safely, because I was going to take the responsibility of managing that patient in the OR without others around to really help me, because on the weekend, you're in the worst case scenario where you don't actually have a resident or a fellow to help you in the OR. And part of me went, yeah, I've been doing this for years, I can do it. And part of me went, oh my God, the last time I practiced donning and doffing was when Ebola was supposed to be happening. And I couldn't even remember when that was. And there weren't any stations set up yet to don and doff, and I didn't have a partner or anything. And I had a family at home that was going, Mother, you are out of your mind. Call somebody younger who can come in and do this case. And I, whether I was foolish or proud or just felt that call to arms that Brittany talked about, I knew that it was my job to do that case that day, and that I was going to step up and I was going to do the best I could. And things went well. How well I donned and doffed, I don't know, because nobody ever watched me. I may have been terrible at it, but nobody got sick beyond that patient. And on the same day, I was dealing with a overwhelming number of emails that were coming in from the hospital saying this. So this is on the Saturday. We don't want your students anymore. They've got to go. We've got to take care of our patients first and foremost. And really what their criteria were that they needed fewer people in the environment. So they didn't want the medical learners there that didn't need to be there, or any healthcare undergraduate students there. They didn't want the patients and families anymore to be in the environment. And really what was at the bottom of all of this is, in spite of the fact that we should have planned better, and we haven't planned well for the second wave either, there just wasn't enough PPE for everybody. And so it wasn't a question of how can I negotiate to keep the students in this learning environment? It was more, how am I going to manage this communication to the students, to the faculty, and at the same time plan really quickly to keep the students engaged at a time where they're thrown out. And so I actually, went to my anesthesia, and what you have to do is prioritize when you're in a crisis situation. It's sort of like ABC, but it was fourth year, third year, second year, first year. So for fourth year, it was like, well, they're close enough to being done. They're good to go. I'm going to kick them out and tell them just finish your assignments that are left and you're going to graduate. For third year, it was, well, we're going to have to sort out how we can move their curriculum into a cohesive curriculum, which it wasn't, and move it online. So gave that to Dr. Bernstein to do. For first and second year, it was like, they have to just accept that, we're paying attention to third year mostly right now, but second year, give us a week and we'll get your curriculum online, and we'll make some decisions around how we're going to manage the ongoing curriculum and student assessment. And I would have to agree that we could have communicated better at that time. But what probably wasn't apparent was how overwhelmed the faculty was just with what was going on in the healthcare environment and the work we were doing in the healthcare environment and trying to attend to the curriculum at the same time. So a week later, still being very much in my clinical role, I was the first person to take COVID airway call for the Department of Anesthesia at St. Michael's Hospital. Now, why they decided that such an old person as me would be the one that would be the first person on overnight to take COVID airway call is still a little bit beyond me. But I had been the chief during SARS-1, and I guess they thought, well, she volunteered to do this. If she could step up and do it, it's a bit of a role model to everybody else. Because there was a huge amount of anxiety at that moment in time as to what was the most appropriate way to manage the airway of a patient who was COVID positive. So I got my rubber boots and I practiced my donning and doffing, and I stayed in the hospital from 6 at night until 8 the next morning, and I didn't get called, but I didn't go to sleep either. I was so anxious that I just stayed up all night. And what I learned from that is that it doesn't matter how long you've been doing this, you never are going to feel, it's not like you can feel, I know that I'm going to be safe. You're always going to be anxious about this. And that's sort of the third thing I want to talk about. And so, and all at the same time, we're trying to get to manage getting the students' curriculum to a point where we think it is at least acceptable, if not, not what we wanted for them. And so the third time that it really came back to impact on me was when 2 months later, we were finally doing cardiac cases again. We didn't do anything but, emergency cardiac for a couple of months. And I went to do an elective cardiac case. And after not having been in the cardiac room for 2 months, I questioned my abilities again. I felt like an imposter walking in there because it just didn't flow naturally. First of all, you're in full gear to do a cardiac case, and you stay in that for hours at a time, which Brittany can probably attest to is not very comfortable. And I just felt uncertain, and I haven't, everybody will at different points in their career. But by the end of the day, I posted a video about, and at the end, it was actually not just that I felt okay about it, but it was just that like I'd returned to home. And that's how I feel about my current experience in the hospital. My time at home, Zooming all day to do my educational work, is not a comfortable environment. There's lots that's good, but not so good about Zoom. And I feel like I'm going home every time I go back into the hospital to do my clinical work, because although it's different than what it used to be, it is still so much more similar to what it used to be. And at the end of the day, it's still taking care of patients to make them as safe as possible. It's been a real journey for me as well. And I shared, when you talk about the things that you all experienced, it's about uncertainty, the lack of communication, worrying about your wellness and the wellness of those around you, feeling safe, and just about staying connected. And so it doesn't matter where you are in your career, you're going to continue to experience these types of feelings. And we are going to have another crisis. I don't know what it's going to be, or when it's going to be, but it's going to come to us again. And maybe this second wave is the one right now. So I'm going to go to the Q&A. And again, thank you. Well, let's see what people are asking. So are there any additional thoughts or ideas that any of the panelists would suggest that the hospitals could do differently to support a safe training environment during this pandemic time? Okay, so this came from, actually, I'm going to call you out. This comes from a VP Education. So I'm going to ask, first I'm going to ask Victor to answer that question, and then anybody else that might want to after that. So Victor, it's what could the hospital have done differently to support a safe training environment?
Yeah, so I think that a lot of the general principles that we're starting to adopt are good progress. I think the biggest piece is the acknowledgement for everyone, not just for the learners, for the staff and our preceptors, our patients and everyone, how uncertain and anxiety provoking the experiences day to day can be, whether it's because you hear about a contact or you know, your unit may become a heightened awareness or outbreak or all those things that are out of your control. And to really implement a couple of things, including a really strong orientation that sets kind of values and principles for the time that people are there, so that people know that, you know, they can reach out to each other, having some designated individuals who are there to support learners, faculties, each other. And then, you know, whenever things are kind of changing, different or whatnot, just being really open in communication, because nobody expects anyone to know all the answers. Testing things can change every second. Whether a learner is in or not can change every second as well. And that's something that we all have to learn to manage overall. But being open in communication is super important there. And then just prioritizing and making people feel from the learner perspective that they are learning. Again, as Brittany noted, we all have to be involved in service. That is part of what we're doing as well. And learning comes through the experience. But especially if, you know, situations where I've had colleagues, or sometimes they've been told, oh, do you want to be the COVID resident, or do you want to be this or that? And they themselves, it's really difficult to say, oh, well, no, I don't want to do this or that. I think there may be very good reasons why one person does only that or whatnot. But again, having that strong open communication and making sure the learners feel supported when they're put in different difficult situations is really critical to ensuring that they'll be able to perform and do the things they need to do.
Thank you, Victor. So another question. Question is, I think it was Jason who mentioned proper accommodations. What accommodations were helpful?
Right. So from transitioning from written examinations, one of the big things was paper and note taking, having a water bottle presence. And when you're being proctored, you can also use the washroom, etc. But when you run examinations, one of the big issues was how do you, again, control for keeping exam integrity as well as being allowed to accommodate for students' ability to write their exams. And I think there's a huge transition from periods of time when how you write exams. So before we wrote it on pencil and paper or pen and papers, or actually pencil paper, and then we moved to pen and papers, and then we moved to computers. And I think it's just with the sudden adaptation and the expectation to perform, it's very difficult. And so some students required more accommodations. And then I understand that there are some hoops that need to be jumped through in order to receive the accommodations necessary, because again, every single student is in a different position and requires different amounts of support. So it's hard to say what actually worked, but I think that there needs to be a conversation around how to make it more streamlined and how do we ensure that every student is supported.
Thank you. So there's a question, and I'll throw this out, or maybe I will ask Dilshan to answer this one. How has this experience changed your approach to your future practice?
Yeah, so I think for me, I was very fortunate in that while the pandemic did have a significant impact on my education, I wasn't in a clinical setting yet where it significantly impacted my clinical experiences going forward. In terms of what I've taken away for future practice, I think from my perspective as sort of a student leader, being the current VP of Education, I think it's encouraged me to, I guess, reminded me of the importance of advocacy for, we were talking about accommodations, but I think it's a very transitional skill to advocate for others who are in need. And I think going forward, that's going to be something that's a little bit more on the forefront of my mind when I am in a position of power in the clinical environment, and I guess being more aware of the needs of learners who are under me one day, and also thinking about, I guess, more creative ways to approach helping students have a unique learning experience. One thing I didn't really mention earlier was while we sort of didn't have an opportunity to shadow currently, one thing that I did to try and overcome that gap was to do my own little version of shadowing, in that I met with mentors and tried to, get them to give me some cases and sort of talk about it with them. So just trying to find like a different approach to still get that experience while still conforming to the constraints that were in during COVID. So I think going forward in terms of future practice, this experience has prompted me to try and think outside the box in terms of how I approach my education and my ongoing life learning, and also how I promote education for those who come after me.
Thank you. Brittany, I'm going to give you this one. What would you recommend we do differently for the second wave than we did for the first one? You spoke a bit about the second wave, and it's not the same sort of, we're all feeling tired, and it's not the same sort of excitement and call to arms. So what should we do differently?
That's a tough question.
That's why I gave it to you.
Yeah, right. I think what we need to do is really think about this in a long-term standpoint. I mean, we're going into a lockdown with 28 days as the initial sort of cutoff, but nothing about this is 28 days. In the spring, there was a lot of chaos with examinations and trying to do things, pivot things very quickly. And I think we need to collectively, from an education standpoint, just start to think about how this is the world we live in now. And so I think, from an accommodations or sort of like orientation standpoint, like as far as Victor mentioned, I think that's absolutely essential. You should have some degree of orientation to residents coming into, be it emergency, family clinic, anywhere where they're going to be seeing patients and needing to be feeling comfortable. And things should be, I think, where we can kind of make things into systems, from a human factor standpoint. You shouldn't be doing your own sort of flavor to how you deal with PPE, et cetera. It should just be a system that is done, that is practiced, that everybody sort of feels like they've got a standpoint of. And I think you guys at St. Michael's did a very, very good job of that in the spring, leveraging SIM that was available and sort of making some of that stuff just, it shouldn't be part of your what you need to concentrate on. It should just be a system that exists with checklists. And I think we can leverage that in different areas to, again, try to make that cognitive load on trainees who are now feeling more stress and uncertainty, just take that cognitive load out of the picture.
Thank you for that. And I would like to, I know Bev Bulmer's in the audience, and I would like to thank St. Michael's that did so much to provide resources to all of the learners in the environment, the staff, the faculty, to have access to simulation and to have the ability to practice over and over again, and now have stations where we can safely don and doff. So there's one more question. It's a hot potato. Given the research on aerosol transmission, do you see surgical face masks as opposed to N95 masks as sufficient to protect the health of trainees and staff? Well, the IPAC people are still the experts in this area. There has been a very, very limited transmission of the disease with the current standards around the use of N95 for any aerosol generating procedures, and otherwise surgical masks and face shields for management of patients. So I think for non-COVID patients, that is, So I think at this time, I'm not actually going to answer the question, but I think what we all have to do is to accept that it is evolving and that we will, as best possible, continue to use evidence. I think we were all somewhat discouraged and dismayed in the beginning at how many times the evidence seemed to change and the recommendations seemed to change. And that certainly led to all of us on the front lines feeling less certain. I think we've gotten to a point where most of us have now had the experience that we now feel safe in the clinical environment. So with that pronouncement on my part, and it's my personal opinion, I will say that, I think we've come to the end, and I'm going to turn it back over to Dr. Myalopoulos to just say, but I'd like to say thank you again to all of our panelists. It's been a great session, and I learned a lot from all of you.
Thank you. I echo that. And thanks to everyone for joining us today, and our panelists and chair for sharing your time and insights. I think learning from our learners at every career stage is key to sustained innovation in health professional education. Our next PIPA rounds will be held on January 19th, 2021 with Dr. Teresa Chan from McMaster University. And I hope you're all able to join us again for what promises to be another stimulating discussion and presentation. So thank you all.